Hello. Hello, Dr. Nina.
Hello, ma'am.
Hi, good morning. Am I
Good
audible?
morning. Yes, ma'am. You are audible.
I
You
just
want to
try to share my
check your
slides to
presentation?
see if they're
Yes.
visible. Yeah.
Yes, ma'am.
Yeah. You can see?
Yes, ma'am. You can make it full screen.
Yeah, I'll do that. Yeah. Is it full screen now?
Yes, ma'am. Perfect.
So just let me know when you have to start. Huh?
Yes, ma'am. We'll around by 11:05 generally we start.
So I'll leave
So
this
the time.
open is fine, no?
Yes, ma'am. You leave it open and
Yeah.
it's still there about 10 minutes. So then
Yeah.
we can begin after that. You can leave it
Yeah.
open.
Sure.
Okay.
Thank you.
Okay, ma'am. Ma'am, we'll wait for 5 minutes for people to join, then we'll start.
Yeah, sure. Yeah.
Okay, ma'am. Hello? Kavita, ma'am?
Hello.
Ma'am, I think we'll start. We have
Yeah, we
a
have
lot of
today.
people have joined in. I'll just
Yeah,
do the introduction in a minute.
sure.
Hello, everyone. So today is our second lecture in our lupus series. Today's lecture is by Dr. Kavita Krishna, who is the professor and head Department of Clinical Immunology and Rheumatology at Bharati Vidyapeeth University Medical College and Hospital, Pune. So on to Dr. Kavita. Thank you,
Yeah,
Dr. Kavita.
thank you, Dr. Nina. Am I audible? Hello.
Yes, ma'am. Yes, ma'am.
Yeah,
You're audible.
and the slides are visible, no?
Yes, ma'am. Slide is also visible.
Okay. Good morning,
We are
everyone.
good to go.
Yeah, so you've had a basic lecture on clinical and pathogenesis and clinical features of lupus. So today we're going to go on to the next step, that is the investigations in SLE. So as you know, SLE is a multi-system disorder, autoimmune connective tissue disorder with varied presentations, with a variable course in different patients. And sometimes it's quite devastating complications what you get. and it affects young patients in the female reproductive age group. And we need to have an early diagnosis and management in order to have a better quality of life. And monitoring is required to assess the treatment response, disease progression, and adverse reactions of therapy. So our investigations, which we are going to look at today, will be moving around diagnosis and monitoring of disease activity and treatment or side effects of the treatment. You must have already done the classification criteria for lupus. So out of these, most of them are clinical. Then there are a few laboratory and immunological, and the most important, the anti-nuclear antibody testing. So any 4 out of 11 will classify this as a SLE, as a diagnosis. So what are the indications for investigations in lupus? So first of all, it is to identify the disease, monitoring of the disease, and identifying the side effects of the therapies that we have, whatever we offer to the patient. So let us see one by one. Why do we need to diagnose lupus early? So the study from Birmingham, there was an SLE cohort where they documented that on an average, a lupus patient may die 25 years earlier than their peers, and the disease progression is variable. So we need to customize the investigations and monitoring in every patient. What are the organs that are involved and what should be screened on the first visit? As you already know, skin and joints are the most prominent organs that are involved. Most of them present with pancytopenia. The other organ involvement is variable. Some get kidney infection first, some present with vasculitis, some can have cardiac or lung involvement, and in rare occasions they can present with pancreatitis. Many come with cognitive dysfunction, seizures, etc. So we cannot do all the special investigations in all the patients up front, but certain investigations should be done in all. Some should be done as per the presentation, and some should be repeated once a year, even if they are normal. Let's see a case scenario. A 28-year-old female presented with fever, body ache, blanching rash since 4 days. This is a common scenario with physicians see, with mild anemia, leukopenia, and thrombocytopenia. Now, with the dengue season, she came NS1 positive, dengue IgM positive. So she was treated this time as a case of dengue fever. However, after 1 month, she again came with fever, fatigue, polyarthralgia, though there was no joint swelling. And in spite of 1 month passed as the dengue diagnosis, she still had a leukopenia and platelets were also low. So this is a time, because she had fever, persistent polyarthralgia, she was advised in anti-nuclear antibody testing, because even the ESR was 54, but she did not want to do it and she took a discharge. So what I want to try to say here is that the trend is moving from infectious diseases to non-infectious diseases. And out of the non-infectious diseases, autoimmune diseases are a very important part of it. So we have to have a high index of suspicion, and advising the right test at the right time is very important. So this patient went home, again came after 3 months with a rash like this. So there was fever, malar rash, rash was also on the forehead and on the chin. And this time she agreed, and the ANA test with immunofluorescence showed a spectral pattern. The blot also showed a anti-Smith antibody positive, and she was diagnosed and further managed as a case of SLE or lupus. Going back to a little bit of pathogenesis, as you all know, antibody response is a culmination of interactions between macrophages, T lymphocytes, B lymphocytes. And when you have antibodies targeting our own tissues, it is a sign of autoimmunity, and these are called autoantibodies. And detection of these autoantibodies facilitates the diagnosis of patients in lupus and also in other connective tissue disorders. But what you need to remember is, though ANA testing is the cornerstone in diagnosis of autoimmune connective tissue disorders, we have to have the background of a strong clinical suspicion. Otherwise, it can get more confusing, as we see in the slides further. Going back to a little bit of history, LE cell or lupus cell, lupus erythematosus cell, was discovered in the bone marrow in 1948 by Hargreaves et al. And his team. They were all clinical hematologists. As you can see in this slide, there is a LE cell with the nucleus of its own and another engulfed nucleus, macrophage, which is engulfed with the denatured nuclear material. As you can see in this slide, that's Professor Hargreaves. And this cell is a large macrophage. It has its own nucleus and also has engulfed the denatured nuclear material of another cell. The exciting thing was that around this time, we also had arrival of immunofluorescence. And this was first tested in the varicella or herpes zoster virus. And while Kuhn et al. In 1942 discovered direct immunofluorescence, in 1954, we discovered the indirect immunofluorescence technique or the sandwich technique, which is used today. So the journey of autoantibody detection is a fascinating one because after this discovered so many ANA patterns, newer and newer antibodies. In fact, if you read the new assays, more and more antibodies are being discovered every day, and the correlation to different connective tissue disorders is quite overwhelming. So at least we need to know the basics. In 1957, the first time ANA was detected by the indirect immunofluorescence assay. And initially we used various substrates, stomach, liver, kidney, mouse models, monkey models, etc., HeLa cell, cancer cervix, chick RBCs. But finally, what we use today is the HEP2 cells. These are squamous cells of human laryngeal carcinoma or the variant HEP 2000. And the biochip technique, which most of the companies use now, one of them being Euroimmune, they use the HEP 2010 cell. Now, what happens? These cells have very large nuclei, so you can detect the patterns easily. It's easier to detect. And parallel, you have a primate or a monkey hepatocyte as a liver. So you have a nucleus large from a HEP 20 to 10 cell and a liver cell for the tissue cell. So both help in the diagnosis of immunofluorescence or with antibodies. So this is a typical ANA slide. Or if you have an immunopathology lab close by, you can go and have a look once just for experience and just to know. We keep talking ANA, what does it, how do they do it? At least once do visit a lab and to see how it is done. We also at Bharati Vidyapeeth conduct an autoantibody workshop once a year. You're welcome to attend that also sometime in April and May. So this is a typical ANA slide where you have HEP2 cell or the cancer cells on the left side. And this is a full of large nuclei which are dividing all the time. So you have cells of different phases, metaphase, without metaphase. And next to it on the right, you have a liver cell. This is a stable tissue. So it does not show you the large nucleus or the different phases of dividing cells, but at least will give you the immunofluorescence which supports the diagnosis. So what are the indications for ANA testing? First of all, one needs to know that serial ANA testing is not used for progression or after assessment. Once you diagnose ANA positive, the most of the monitoring is clinical. Only certain tests should be done for monitoring. You don't need to repeat ANA again and again because this does not correlate to the flares. Now, which are the conditions where ANA is 100% positive? Mixed connective tissue disease, autoimmune hepatitis, and drug-induced lupus. In these three conditions, ANA has to be positive. It is a part of the diagnostic criteria. In other diseases like lupus, Sjogren's, scleroderma, inflammatory myositis, Raynaud's phenomenon, etc., ANA will help you in diagnosis along with other diagnostic criteria. In juvenile idiopathic arthritis and Apla syndrome, etc., it helps more in prognosis rather than diagnosis. Who are ANA positive has a more severe course, like, more progressive course, and we need to tackle them more carefully. But there are other conditions like rheumatoid arthritis, psoriatic arthritis, Hashimoto's, myelomas, fibromyalgia, where ANA may be positive but does not add to the diagnosis or prognosis. You have to look at other classification or diagnostic criteria. So again, the similar slide, but what I want you to see is the last part of this slide. Normal individuals also may be ANA positive. If you can see, about 1 into 40 titers may be seen in as much as 20 to 30%, 1 in 80 in 10 to 12%. This is mainly in females who are middle-aged or elderly. Even more than 1 is to 320 titers can be seen in 3%. So you have to have a good clinical correlation. Don't just diagnose lupus if ANA is just positive. So now let's come back to a lupus patient. What do you screen in the first visit beside the diagnostic test? So this slide shows you basic tests. ESR, CRP are very important. ESR tells you by and large how much is the inflammation, how active is the disease. CRP also will be high, but remember, if the CRP is out of proportion higher as compared to the ESR, look out for infection more than inflammation or active lupus. Complete blood count has to be done on every visit along with differential blood count. Renal parameters, should be done initially. And then if there's no renal involvement, on a regular basis, you should keep checking for creatinine, urinary status, whether it's proteinuria, any infection or sediment in terms of RBCs and CAS. Keep checking the GFR. Urine spot protein creatinine ratio or a 24 hours protein should be done regularly as required. If you feel there is proteinuria, of course, you have to check more frequently and then monitor therapy also. Autoantibody, we'll talk a little more about it. So you have ANA, that is the immunofluorescence auto anti-nuclear antibody. Then you have the different antibodies which are detected by the ANA blind blot or ENA, that is extractable nuclear antibodies. And you can separately do ELISA tests, especially for anti-dsDNA antibodies. Special tests should be done only when you're suspecting lupus nephritis for disease activity like C3, C4, where you think there's a thrombosis ongoing. You can check the APLA, lupus anticoagulant. If you have a pregnant patient going in for, who has lupus, or a lupus patient planning pregnancy, then APLA profile is very important because we have to anticoagulate this patient, explain the risk to these patients. Liver function tests should be done in patients basic, and then for monitoring therapy. If the SGOT is very high, then there could be muscle involvement. Then you need to check the creatine phosphokinase or LDH or aldolase. Imaging as and when required needs to be done. We'll talk more about it. So this is an overall idea of what tests you should be doing in a lupus patient, but some of them need not be done every time. So when you do the hematological or a complete blood count, most important is anemia. There could be leukopenia, as I said. There may be lymphopenia, and anti-leukocyte antibodies may be present. If there is hemolysis, like indirect bilirubin is high in the LFTs, think of an autoimmune hemolytic anemia. There you need to do a direct Coombs test to document, because there they just become anemic very fast, hemoglobin drops. Most of them have anemia of chronic disease. They may have associated iron deficiency. If they develop lupus nephritis, again, the anemia will increase. Many of them have thrombocytopenia. They may have associated anti-erythrocyte antibody. ESR, we've already talked about, usually is elevated in active disease. So when you monitor, we always check the ESR. CRP also will be high, but if it's very high, then rule out infection. So coming back to our anti-nuclear antibody done with immunofluorescence. This is a very sensitive test, and now it's been by the ACR criteria, is a gold standard for diagnosis of SLE. Anti-dsDNA we usually do by ELISA titers, because immunofluorescence requires a different substrate and it's difficult to do everywhere. This is very specific again for lupus and correlates better in lupus nephritis. ENA. So when we had ANA by immunofluorescence, we have certain patterns which suggest certain connective tissue diseases. But if you want to test individual antibodies to individual antigens, so these nuclear antigens were extracted from the nucleus, and then you can run a line blot assay. So this is a typical ANA by immunofluorescence slide, where you can see the first line says it's positive or negative. The second line says it's speckled, means what pattern you can get. Then the grade or intensity, 1+, 2+, 4+, etc. And the dilution titer. Dilution titer means at what maximum dilution it is still positive. So higher the titer, more sensitive or more definite is your diagnosis. This is a typical ANA slide. On the left side, you have control. On the right side, you have the ANA immunofluorescence slide. So left is almost not seen dark. So this is a negative versus a positive slide. This shows the different patterns. If you can see, the left top corner shows a homogeneous pattern. This is the nucleus of the Hep2 cell, large nucleus, no specific pattern. It's positive, but you can't see anything. The whole thing is uniformly immunofluorescent. This is a homogeneous pattern, most commonly found. The second one, only the rim is highlighted. That is a peripheral rim pattern. The third one is again a commonly seen pattern, which is called speckled. You can see nice dots which are highlighted. This is a speckled pattern seen with anti-Smith, anti-SCL70, in Sjogren's, in lupus, etc. And the nucleolo pattern, where the rest of the nucleus is not highlighted, but certain dots are there. This is our nucleoli. So these are more specific in scleroderma. So when we have certain pattern, these are the, as I already said, these are the certain illnesses you will think of. Could be lupus, could be Sjogren. These give you clues. These pattern give you clues that, because what happens is the antibodies go and attach to certain parts of the nucleus, certain phases of the, division of the nucleus. So that is why these patterns give you clues. So over the years, they found that certain patterns correlate with certain types of connective tissue diseases. But sometimes there are a lot of mixing and confusion. That is why you have the next set of tests. Sorry, before that, we should just see the intensity. So you see 4 plus, 3 plus, 2. The extreme right is there's no immunofluorescence. Then it's light, then it's darker. So with the experience, you will see that as it gets darker, you label them as 2 plus, 3 plus, or 4 plus. So higher the intensity, more sensitive, more specific, more likely that the patient has got lupus or a connective tissue disorder. And dilutions, you do serial dilutions. Standard dilution is 1:100. But if you want, you can do higher dilutions. And then the highest dilution at which the immunofluorescence is seen, that is what is given in the report. Like that report, we saw it was 1:3200. But for convenience, we just do 1:100. Serial dilutions only when it's necessary because it requires a lot of technical personnel, a lot of time also is there. But this is what dilution is about. So I talked about the different antibodies, extractable nuclear antigen profiles. So you take specific antigens and you run a line blot. As you can see in the right side, there are 2 ANA line blot assay reports. You may find patients come with these reports directly. So you have the control in the bottom line, and you see the control is a long bar and the others are short bars. So they're graded 1 plus, 2 plus. And according to these, you see which antibody is positive. The lower right one, you can see the control is small, but the other antibody bars are longer. So this tells you these are 3 plus, etc. So in the left table, you can see. So each antibody correlates with certain autoimmune diseases. So lupus, maximum you see anti-dsDNA, anti-Smith. Now, Smith was the name of a patient, not of the doctor who detected this antibody. UNRNP is more in mixed connective tissue disease. Rho, La, SSA, SSB can be seen in Sjogren's or in lupus. Antihistone is classically with drug-induced lupus. So drug-induced lupus is classically the common drugs that we use can cause drug-induced lupus as isoniazid, your commonly used antituberculous drug, besides the nitrofurantoin, hydralazine, etc. So when you get an antihistone positive, don't jump to a diagnosis of a lupus. Look at the drug history, what medication the patient is taking. So omission of the drug can cause recovery, can lead to recovery in this patient. Antiphospholipid antibodies are associated with arterial venous thrombosis, pregnancy, morbidity, etc. So various antibodies can be detected on this line blot assay because the ANA immunofluorescence is the gold standard for screening, but eventually the pattern may or may not tell you everything. So you should go for a line blot assay also. This is another ANA blot report. You can see SM, RNP, SM. Now, RNP is never alone. It's always with SM, but SM can be alone. So if it's only SM, it's lupus. If both are positive, it could be an overlap. It could be lupus alone. So clinical correlation is very, very important. Again, now each antibody also tells us which organ is predominantly likely to involve. Though lupus is like a multi-organ involvement, though anything can happen at any point of time. Some patients progress slowly, some patients progress fast. But still, if you got certain antibodies positive, you know, okay, what are you looking at? So whenever dsDNA is positive, renal involvement is very likely. So you monitor the renal parameters and proteinuria more frequently in these patients, and people watch for lupus nephritis because they have to be managed more aggressively, and it can lead to chronic kidney disease if not handled in time. Rho is usually skin involvement. Mothers who have got lupus, their babies, neonatal lupus, they can have associated Sjogren's or myositis, overlap syndrome. Smith is 99% specific for lupus, though it is not positive in all. Only 30 to 40% may be Smith positive, but if it is positive, it is definitely lupus. And you have to treat it as lupus, but many a times it is not positive, but it does not tell you any specific organ that could be involved. It is a non-specific for organ involvement, but otherwise very specific for lupus. Histone we already discussed, and so also antiphospholipid antibody. Let's look at another patient. This is a 28-year-old female, came with fatigue, body ache, pain in all the joints, and this classical malar rash. You can see the erythematous rash on the cheeks and on the chin with nasolabial sparing. So this is a typical butterfly rash, high SR, low WBC count, lymphopenia, and her anti-nuclear antibody and anti-dsDNA was positive. So at that point of time, she was not having any renal features, no proteinuria, nothing, but only this was positive. So we put her on hydroxychloroquine and low-dose steroid. She got better and she was falling. But after 2 years, she started developing periorbital and pedal edema. So our suspicion with that anti-dsDNA was quiescent for 2 years, but she progressed to a lupus nephritis. So what do we do when this patient develops, or you get, so basically you have to work up for the renal involvement. So you should screen in the beginning, but you should also keep monitoring. So renal parameters, you check for the urine routine, for pus cells. Now pus cells can be a part of infection. You can have sterile pyuria also. So if there is no infection, pus cells could be a part of the nephropathy. There'll be proteins. Then if there are proteins, you check for urine protein creatinine ratio and look for sediments. If there are sediments like RBCs, cast, it is a more sinister disease. You must have already been taught about the grades of lupus nephritis from minimal change to class 6, where you have advanced sclerosing lupus nephritis. So the time that you have to act fast is type 2 to a class 2 to class 5. That is when the therapy helps. And these, of course, you should do a kidney biopsy, which again should be done with an immunofluorescence. So these are the few slides which how a kidney biopsy slide will look. So you have to involve the nephrologist and send it for This turns out a little expensive. So many patients are not willing, but you have to convince them, especially the proteinuria is significant. So you have these are the, on the left top, you can see a typical HE slide, hematoxin eosin stain. On the right top, you have immunofluorescence slide, and the bottom one is electron microscopic. So these all show capillary involvement, intercapillary involvement, a lot of inflammatory exudate. What are the special tests? Now you got a moderately or severely active lupus. So you do the complement levels, that is C3, C4. As you know, in lupus, the complement pathway gets activated. So the complement levels fall, C3 falls more than C4. So low complement will suggest disease is active. There could be acute flare. It happens in lupus nephritis, can also happen in vasculitis. So low complement levels should not be taken lightly, and the patient should be treated aggressively. Besides that, APLA, as I said, you should do the entire profile whenever possible, because just an APLA IgG IgM is a blanket test. So you can do mini APLA, which is slightly cheaper. And lupus anticoagulant is most important out of these. So in pregnant patients, if any of them is positive, you should be more aggressive with your anticoagulation. In other patients, we do it when there's evidence of thrombosis. And if they're positive, if they have lupus or they're pregnant, you have to give very good anticoagulation. Otherwise, the patient will land up with thrombosis in some major organ or the other. Liver functions, you should do baseline, and in between, you have to do them for monitoring for side effects of medications. They can have transaminitis, but if SGOT is much higher than SGPT, you should also rule out myositis or muscle involvement and do CPK, etc. Bilirubin could be high, indirect bilirubin can be high if there's a hemolytic anemia, as I said, autoimmune hemolytic anemia, or they could be sometimes associated autoimmune hepatitis with other antibodies positive. So then you have to involve the hepatologist also in your management. Coming to imaging. So upfront, all of them may not need imaging, but when they are sick and when they are breathless, a lot of imaging needs to be done. And clinical suspicion, don't hesitate, admit them, because lupus, when they get worse, they are catastrophic. So they need care at a bigger hospital, a tertiary care hospital, because multi-system involvement, you need to involve the pulmonologist, the nephrologist, the physician, the etc. So do not try to manage a critical patient in an OPD setting. So involvement can be in lung. So basic chest X-ray can be done, but it becomes more important when they've got fever, they're breathless. So they could have infective pneumonitis, they could have lupus pneumonitis, but you have to first rule out infection. They could have pleural effusions, pleuritis as a part of polyserositis. Severe complications could be diffuse alveolar hemorrhage, a shrinking lung syndrome. Sometimes you don't find anything, but one lung looks shrunken, the diaphragm is pulled up, so it could be shrinking lung. Infections, of course, is very challenging to manage in these patients, because every time you do a lot infection, they are prone to infection, and they can also have lupus related lung complications. So CT thorax helps to some extent, but still sometimes it's not easy to diagnose the real cause of lung involvement in many patients. If the patient has a lot of tachycardia, ECG is a must. And it can be because of myocarditis, it can be because of pericarditis, where there'll be ST elevation. And some of them, as you can see in this picture, there's a rim of pericardial effusion. This could be a part of the polyserositis. So these are sick patients, which you need to manage very aggressively. Echo is important to document myocarditis, ejection fraction, to see whether they have LV failure. Some of them, just the LV function just drops, ejection fraction drops to 10 to 15%. They could have pericardial effusion, endocarditis. You must have read about Liebman-Sachs endocarditis. And some infective endocarditis is not very common, but they can have varicose Liebman-Sachs endocarditis. So all this needs to be documented by echo. Let's look at this patient. This is also a lupus patient, but she had something different. Besides the rash, you can see the chalky, sort of discharge from the chin. There's some, sinuses like things. And on the back, she had an extensive, some discoloration. Again, with this chalky white thing, she was in so much of pain, these white chalky discharges, that she could not even lie down. So this is a case of calcinosis cutis and lupus paniculitis in a case of lupus. So these things are rare, but if they happen, you have to pick them up. You should keep examining the patient thoroughly. That's what I meant. And these patients also have soft tissue calcification, as you can see in the sides of the pelvis and the chest in the soft tissue, and in the thighs over here. So when you have lupus alone or lupus with overlap, this also can be a complication. In muscles, they can have myositis, so CPK, SGOT will be high. You can do an LDH. And if the muscle pain is very severe, but your CPK, etc., is normal, you can do an STIR MRI of the whole body. And you can see with the black arrow, these are in signs of myositis. So they can be there in polymyositis, dermatomyositis, but also in lupus. Again, the line of treatment becomes more aggressive. See, these are not routine tests we do, but you should know that they need to be done sometimes. Another thing which you find in lupus patients, they are on steroids for so many years that they develop osteopenia, osteoporosis much early. And before they come with fractures, you have to keep a high index of suspicion, where you feel there are, the patient has been on steroids more than 20, 30 milligrams for more than some years. You can regularly do a DEXA scan or for scan for osteoporosis. And if the T-score is much higher, more than minus 2.5, you can think of giving bisphosphonates. So treating the osteoporosis early in these patients, it should be there at the back of your mind. Do not forget calcium, vitamin D, and timely treatment of osteoporosis. Besides this, after you have diagnosed and you've done the clinical testing, whatever you felt was required, repetition of tests is very crucial. You cannot tell the patient to keep on spending on everything. So you have to keep doing it as per the clinical symptoms or the initial presentation that the patient had. So it has to be customized as per each patient. Keep screening for comorbidities. Many of them become diabetic. Many of them are already hypothyroid. So keep checking for sugars and thyroid function. If they're already middle-aged, they get early MIs, they can give atherosclerosis, etc. Vaccination is very important. So ask them every time, are you vaccinated, etc. Vaccination status is also important when you treat them, because the timing of the immunological drugs, biologics, rituximab, etc., has to be decided at the time of vaccination. Influenza vaccine, especially. Otherwise, you give the vaccine and next day you give you've given a drug like rituximab and then you give a vaccine. Patient will not develop any antibodies. So this is a part of monitoring. So what is therapeutic monitoring? You diagnose, you started treatment, then what? When are you going to tell the patient to come back? 1 month, 3 months? So that again depends on each patient. So this clinical monitoring and laboratory monitoring, both are equally important. So initially you should call the patient more frequently, say once a month. And then maybe if you feel the patient is not having very active disease, you can go for every 3 months, etc. So you have a lot of disease activity scores. In a busy OPD, it's difficult to do all, but in lupus, you must do at least some form of scoring. And so that you are aware, you can quantify the disease activity and you're more scientific in your treatment. And these scores you should also know for your, entrance exams, etc. So the most commonly used is SLEDAI 2K score. And you can do it over the last 30 days. So if you're calling the patient every month or every 3 months, you score on the last 30 days. You did not include the last previous clinical features, etc. And the limitations of this score are that sometimes you'll see the score. I'll show you the score chart. Certain partial worsenings you may miss. So don't go by the total score, but still, nevertheless, it helps you to say whether the disease is active or is worsened. And certain parts have been given more scores, and a lot of other scoring which will be beyond the scope of this talk. But you can just know that there are a lot of types of scores. These scores are very important in all the drug trials that we do. But at least the SLEDI we can do in your OPD if you're managing lupus patients. So in day-to-day practices, as I said, you should monitor one score at least. So this is a typical SLEDI 2K. On the left-hand side, I've just put like the neurological involvement is there on the top, which is the most important, the vasculitis and arthritis. And then laboratory, and then there could be mixed features also. On the right side, you can see it's a 105-point score, and 8 points are given to the neurological symptom because there the mortality is very high. Even vasculitis is important. Renal has been given 4, but they've given 4 separate points to urine, hematuria separate 4, proteinuria separate. Again, renal weightage is much more. The reason they've done this probably because these are more aggressive treatment, require more aggressive treatment, morbidity, mortality is high. So you should at least know what a SLEDI is. If you're managing lupus patient, you should also know how to do it. And also for your exams, you should be aware that these scorings are there. How often to do? Yes, every visit you should do, but at least once in 3 months, or if the patient is worsening according to you, or you want to document, oh, patient is better, so I want to de-escalate her treatment. So preceding 30 days, you ask questions and you score and grade. You need not include the old features at time of presentation. So I'll just show you two, and before that, so besides the SLEDI, you should do a 3-monthly hemogram, ESR, CRP, liver, renal functions, urine. So by and large, these tests should be done at least 3 monthly. If something is grossly abnormal, you can do once a month also. If everything is normal and you feel nothing else needs to be done, so once a year, get the eyes checked for fundus. If the patient is a hydroxychloroquine, they develop bullseye vision or maculopathy. So many of them develop premature cataracts, like, at the age of 40, 35, they develop cataract because of the steroids. And if you're worried there's active disease, check the complements in a dsDNA titer of little proteins which has come up, because renal flare should be detected early. So these are the two, I put 2 SLEDI charts here, which the first one shows that the patient's SLEDI score is 13. You can see that there's arthritis and there's new rash, alopecia, etc. So this is moderate, And the other one, this patient was more sick. So you can see a score on 3rd October, where also the score was 21. And subsequently in April, when she got worse, the score went to 28. What you need to note here is there was vasculitis, there was arthritis, there was proteinuria, newer rash, etc., low complement. So this was a sick patient. So definitely the disease was very active. So these give you some clues according to the, means clinically you're seeing, but this quantifies your disease activity. ANA, as I said, does not correlate with disease activity. So do not keep repeating it. ANA titers do not correlate with disease activity. dsDNA titers do. Complement levels, as I said, C3, C4 are low and C3 is lower than C4, or you can get a ratio C3 by C4 less than 0.5. And besides that, they can also be important in high disease activity and vasculitis. dsDNA, as I said, correlates with disease activity. So there you can do a titer by ELISA, and this correlates with lupus nephritis, correlates with an ESR. This is an important investigation. Some special situations, you will find some patients who are on treatment like tacrolimus and voclosporin. So their drug levels are also important. So usually this is not started by a physician, it will be started by a rheumatologist or a nephrologist. But you should be aware that tacrolimus and voclosporin, I think it's not available yet, but these you have to do drug levels and watch for hyperkalemia, etc. Side effects of the medications. Do not just give it because you have to keep checking, is the patient done the drug levels, or send them back to the rheumatologist or the nephrologist, so that we don't get adverse drug effects. Hydroxychloroquine, as I said, can cause maculopathy. Rarely it can cause QTC prolongation and sudden collapse. So you may need to do ECG in between. Now, when is the patient in remission? Is remission good required, or even low disease activity is enough? So these are important because when they are in remission or have a low disease activity, it's unlikely that they will have an adverse outcome. So remission can be diagnosed clinically by serology, how much duration the patient is requiring to, go to remain with good labs and clinical signs, and how much time the treatment is being given. So we have these scores, but by and large, when the patient goes into remission, steroid requirement goes to below 7.5 milligram, and the SLEDAI, which we said can go up to 104, comes down to less than 4. In renal remission, you have to at least reassess at 6 months to decide whether the patient is responding or no. Usually, when we give MMF and cyclophosphamide, we assess at 3 months to check the urine protein creatinine ratio, C3, C4, and at least there should be 50% response. And at 6 months and 1 year, you decide is the patient responding or no, because you can't keep doing a kidney biopsy again and again. But after 1.5 years, if the patient is not responding, you may do a kidney biopsy to see whether the patient is going in for a chronicity just with disease activity. So there may be a role for repeat kidney biopsy, but it's very difficult to convince patients, plus cost issues are also involved. But at least you can do a protein urea, PCR, and a 24 hours protein test along every 3 to 6 months. You must know a few newer molecules which are in the diagnosis and monitoring of lupus, which are slowly coming. And for your entrance exams also, this will be useful. These are called EC4D and PC4D. These are the split fractions. We know that the complements become low, but these if they are positive, so that means they are definitely significant in high disease activity. So you have something like an AWISE lupus monitor. A patient who comes from a city or abroad may have these reports, so she should know what it means. So EC4D are split fragments of the complements, and they correlate better with lupus disease activity than low plasma complement levels, because complement low can be in many conditions, but if EC4D split fragments is elevated because they are the activation products, it correlates better with activity. And if the PC4D, that is the elevated platelet bound rises, so that means there's a higher chance of thrombosis in lupus. So you can check the APLA, etc., and give anticoagulation to these patients. So this is an AWISE SLE monitor. You have a panel of tests that are advised, and this is the way the report looks. So you should just be familiar that these tests are also going to come, and you're familiar, okay, this patient had this high, so I should refer early and get an opinion. So this is just the last slide. You can just see this is a little different case. A 62-year-old female, chronic rheumatoid arthritis. You've been taught rheumatoid arthritis on methotrexate for many years, almost 20 years, and she was quite pain-free, though she was having deformity. Suddenly comes to the hematologist with a WBC count only of 800. So she was diagnosed with methotrexate toxicity, but the relative kept saying she's on it for so many years. So why should the WBC count drop now? So you should rule out other causes like some fever, infection, dengue, etc. So rheumatoid arthritis wise, there was no doubt she had all deformities. But what they said and what I noticed was that she had a lot of loss of hair suddenly in the last 6 months. So much alopecia can happen with methotrexate, but not suddenly out of a sudden, just over 6 months. Okay, so here we did besides rheumatoid factor anti-CC, which she was positive, she also turned out to be ANA immunofluorescence and Smith antibody positive. So what you need to remember here is certain patients who are diagnosed as one rheumatological illness can evolve into another. So connective tissue diseases, autoimmune disease often is a spectrum. It can start with one, but over the years it can evolve into another. So we need to monitor them closely. Thank you. So that's with my slides. I can take questions.
Hello.
Yeah.
Ma'am, that was a really very lucid and very beautiful talk. And because all the students definitely was, as even practicing consultants, everybody has a lot of doubts
Yeah. So thank you. I'll just
about
see chat box. There are some
the
questions, I think. Should I take that first? Yeah. So there's Ashish here. If a patient has infection like lung, fungal pneumonia, extensive tinea, low C3, low C4, mildly low. So what do you do about immunosuppressants? Yes. So of course you have to treat the pneumonia that is there. Skin, yeah. Sorry. I can't hear.
Help us.
Sorry.
Hello.
Yeah.
Hello.
Yes. I can't hear. Can I just answer that question? Okay, I'll just take that question because I can't hear anybody. Am I audible? Yeah. So if you have a fungal pneumonia, so obviously antifungals will have to be administered. You can do a bronch and document, or sputum, which shows you with the pulmonologist, give the right antifungals. Extensive tinea is more with the dermatologist, so you can give the antifungals as required. Now, with fungal pneumonia, obviously all the immunosuppressants have to be given with care. You can give hydroxychloroquine, is tolerated. Steroid, you can go on a dose which is tolerated, which you'll have to give because you do not want a lupus flare. So under the cover of antifungals, antibiotics, you can give. If the patient is very sick, so obviously you can't give rituximab or mycophenolate mofetil. And if the patient is very sick, then you have an option of IVIG in some of the patients if the patient is very sick. Otherwise, you have to control the pneumonia that is there and then slowly add your mycophenolate mofetil. It depends what organ you're treating. It depends what organ you're treating. So then you have to treat both. Whenever you have a severe infection, you have to treat the infection, and the immunosuppressants have to be titrated as per how sick the patient is, because you cannot suddenly de-escalate the steroids also. So rule out bacterial infection also. And antifungal, local antifungal is not a problem. The systemic antifungal, regarding tinea, the local medications for tinea are not a problem. The topical creams, the systemic medications that are there, some of them have severe toxicity, so sometimes they have to wait because of liver dysfunction, etc.
Hello.
Yeah, I'll just
Ha,
stop.
ma'am. Yes, one more question in the chat box is how useful can be anti-La if a patient comes with that report? It is said to be positive in settings where anti-Ro is positive.
1 minute. There's one more dsDNA also. Can you read the anti-La?
Yes,
Yeah.
ma'am. Yes. Repeating dsDNA, how useful it is.
Yeah, repeating dsDNA, I already told in my slides. So dsDNA repeating, if you think there is a lupus, so you can do once a year. It's not recommended again and again. Or you think there is a proteinuria which is coming up, or so there a dsDNA titer is useful in lupus nephritis. That you can, and the titer is important there, along with the ESR and the proteinuria that you have. So you can repeat a dsDNA titer by ELISA. How useful can be anti-La? If a patient comes in with that report, it is said to be positive in settings where anti-Ro is positive. Yes. So here again, with La, SSA, SSB. So anti-Ro and La, SSA, SSB. So these are important for Sjogren's, lupus. These are the two important settings. Very occasionally in other connective tissue disorders, they can be positive. So if a patient has no features of anything, so you just have to wait and watch. If a patient is going to get pregnant, then these are very important because there can be, heart blocks in the baby. So there it is, we have to monitor the patient very closely. And clinical features matter more over here. So you should not just go by a blot report. You should also do the ANA by IF and see what pattern it is, clinically see, and then see what the clinical features in favor of Sjogren's. Is there dryness? Is there a Schomers? Is there a rash? So it is not just the Ro and La report. You have to see the patient clinically also. Significance-wise, anti-Ro again can be standalone positive, where it can be in many other conditions like inflammatory polymyositis, pulmonary involvement, etc. And if both are positive, Sjogren's, etc., is more likely. Other conditions where it is in SCLE, subcutaneous lupus. So in a lupus, if Ro-La is positive, the skin manifestations will be more dominating in those patients. One patient is admitted with us, known case of rheumatoid arthritis, now came with sudden hemorrhagic effusion. We have put an intercostal drain. What should we suspect? Unilateral effusion. She was on methotrexate. We have to do ANA, suspect lupus. Okay. So hemorrhagic effusions not very common in rheumatoid arthritis. That is one. You can do an ANA, but I think for hemorrhagic effusion, look at other things, besides lupus here. She doesn't have any other signs of lupus. I think before that, rule out infection, pneumonia, some malignancy for that matter. And you need to see the CT scan, what is the left lung involvement, etc. Was it traumatic? What is the platelet count? So if there's severe thrombocytopenia by chance, so it could be hemorrhagic manifestation. But don't go think of lupus right away here. Please advise regarding anticoagulation treatment for E4CD is not available here as yet. So when it is available, the platelet one, the P4CD is more important. Anticoagulant treatment in lupus nephritis, standalone, it is not given for all. If there is an APLA positive, yes, you should do. Patients who have lupus nephritis also have an underlying risk for atherosclerosis. So plain aspirin would do with the statin. But all lupus nephritis patients need not be on anticoagulation. You see the APLA profile also. Yeah, Dr. Nina, I think I've done with the questions. You would like to contribute to any of the questions? Dr. Nina, you there?
Ma'am, one more question is there. Did we answer this long-term? Sorry, 1 second. Antiphospholipid treatment in pregnancy with anticoagulation.
Okay, no, there are more questions. Okay, fine. Antiphospholipid treatment, specifically anticoagulation. Yes. So you have to now, this patient, we don't know what is the past history. So when is APLA tested in pregnancy? One is a patient with bad obstetric history. One could be a patient who's, taking treatment for infertility and they do the APLA profile. Third is our lupus patients or connective tissue disorder patients. So if they're APLA positive, then they have to be on anticoagulation throughout the pregnancy. Now, the question is whether to take a low molecular weight heparin throughout pregnancy or you want to give warfarin also. The first trimester, no warfarin. Second, third trimester, you can give warfarin, but you have to omit a couple of weeks before you're planning the termination of delivery, LSCS or whatever. Ecosprin also. So we give low molecular heparin and aspirin to these patients throughout pregnancy. And a couple of weeks before, 1 week before, you may stop the aspirin. Usually the gynecologists do not want aspirin till the end because if they're going to take up for a Caesar, but anticoagulation has to be given to all these patients. Bisphosphonates, till what level of steroids to be monitored with the DEXA scan? Yeah. So if you're going to give more than 20 milligrams of steroids for more than 3 to 6 months, so you should do a DEXA scan at least once in 3 to 5 years. Very young patients, you may not do right away, but patients who are 35, 40, you can do. Or patients who have vague bone pains, etc., you can do for them. And then you have, of course, first you have to give calcium, vitamin D. That should be supplemented first. Then you can offer them. They can have, they can be on bisphosphonates. If you're able to tolerate oral, then you have alendronate once a week. You have ibandronate once a month, or IV zolendronate. So many of them, they're already on so many tablets. So if they are willing, you can give zolendronate IV once a year for 3 years. And after 3 years, you can decide whether you want to do a DEXA scan again. If the patient already has some sort of a fracture, you have the option of teriparatide. You should insist. Teriparatide is usually a daily injection for at least 1.5 years. They should not keep stopping and they convince the patient to take it daily. The third option in middle-aged elderly lupus, if they have fractures, is denosumab. So osteoporosis is again a treatment which is not to be taken lightly. So all patients who are on steroids more than 20 mg for more than 3 months, at least give them calcium, vitamin D. And then maybe after 3 to 5 years, you can start doing a DEXA scan. It also depends on the age of the patient. And you can involve the endocrinologist here to decide about further treatment of osteoporosis. How often do we repeat C3, C4 in such cases with infection? Okay, the first Ashish, this C3, C4, you don't monitor for infection. So you think the lupus nephritis flare is there or there's a vasculitis flare, you can do. So you don't really need to do it very frequently. So you can do after 3 months or once in 6 months or whenever you think there's a renal flare. In disease activity, actually it confuses us. C3, C4. So there you can go with ESR and other signs. But elevated low C3, C4, out of which C3 is lower than C4, is early sign of lupus nephritis. So you have to correlate. If there's infection, you treat the infection only first. If there is proteinuria, then you take it as a flare of the lupus nephritis.
Ma'am, the next question is about autoarthritis. So that I've answered that it will be covered in the later sessions.
Yeah.
So we can skip that. And the last question is, if a patient on is on steroids develops a fracture, then do we continue steroids?
Yeah, so that again becomes very tricky because if you take away the steroids totally, then they may go a lupus flare. So you have to try to give them the lowest possible dose of steroid, assessing the disease activity. If you can't reduce or taper or stop it, then you have to, along with it, give calcium, vitamin D, and then the fracture has to be treated more aggressively. So here you give teriparatide along with calcium, vitamin D, and nowadays they recommend add-on denosumab also. So teriparatide, as I said, is a daily injection, 20 international units, subcute on alternate thigh. You should teach the patient. Compliance is very important. They tend to stop it, and it's expensive also. So every day on alternate thigh, subcute for 1.5 years. You don't extend it beyond 1.5 year. Along with that, you can give denosumab, which is once in 6 months. Steroid, you try to bring it to the lowest dose, but you have to, maybe if the patient is on a steroid sparer, you can escalate that, like if the patient is on mycophenolate, mofetil, etc., whatever the situation is. So you can come down on the steroid dose, but you should not suddenly stop in lupus. Otherwise, they will land up with a lupus flare.
Yes, ma'am. So
Sjogren's,
next is about Jogren. So I've answered to them that it will be again a separate session
yeah, it will be
complete.
a repetition here again. Yeah.
Yes, ma'am. So I think regarding lupus, all the questions have been well taken. And
Okay.
it's been a very nice interactive session. Thank you very much, ma'am. This time we had a really good question answer session.
There's one more
Thank you very
question.
much.
I think you want to take that. This looks, I should
Yes,
answer.
ma'am, we can
Yeah, yeah. So
take a
patient with
last one.
lupus, only leukopenia responding to hydroxychloroquine and steroids. Any other immunomodulator therapy causing leukopenia, can we just continue with HCQS and 5 milligram prednisolone with OPD management? Yeah, if there is no systemic involvement, you can definitely continue with OPD management. You have to see how severe is the leukopenia, calculate the absolute neutrophil count, and then you have to see whether they are prone to infections. By and large, if the count is remaining below 3,000, below 2,500, you have to step in. So you can add mycophenolate mofetil if required. Yeah. And look at other organs. Sometimes, yeah, you don't need to admit them, but you have to give them advice like wearing a mask in crowded areas, because they are prone to infections. So HCQS steroid, you can hike up steroid for some time and see if they're responding to the hiking dose of, say, steroid like 10 or 20 milligram. And then when you're trying to taper the dose, that time the count is falling, that means you can add a steroid sparer like mycophenolate mofetil. And some people give azathioprine also because it's a autoimmune leukopenia. But then you have to be very careful with the azathioprine because it can also cause hematological toxicity. So if your hiking of the steroid was helping in the leukopenia and reducing it is again worsening the WBC count, then you should add a steroid sparer. And admission is only if they are getting infection or it's very low. If it's going below 2,500, 2,000, serially drop, then you should be more aggressive. Yeah. Okay, I think.
And I think I like to add here that many of our lupus patients, their counts remain between 3,500
Yeah,
to 4,000 and they are very stable.
yeah, so
So
we can wait, like
yes,
that. The 3,000, 3,500 is fine.
yes,
Serial monitoring is more important, and they should be told
absolutely.
about infection prevention, like mask and all in crowded areas, because they catch
Absolutely.
infections very fast. Another thing is vaccination. They should take their influenza and pneumococcal vaccines. So,
Yes,
that will prevent frequent chest, especially like in the month of May. All of them you should advise the influenza and pneumococcal vaccine in April and May before the monsoons, or if they miss it, then before the winter, October.
yes, ma'am. Yes, ma'am.
I think.
Thank you so much, madam. Thank you.
Yeah.
I think
Okay. Most welcome. Yeah. Bye
looking,
bye.
thank you. Good day.
Yeah.
Bye
Have a
bye.
great Sunday. Bye, all of you. Yeah. Okay.
Thank
Thanks for
you.
being here.